Hello friends, today we are going to discuss about clinical schedules for primary care psychiatry. I am Dr. Suresh Badadmat, Professor of Psychiatry working at NIMHANS, Bangalore. In this video, I will be discussing about clinical schedules for primary care psychiatry version 2.2. This schedule was developed by Dr. Manjunath and his colleagues. This schedule is utilized for training primary care doctors, general hospital doctors, family physicians, or any specialist who are treating chronic illness. That means for training in psychiatry, especially with regard to common mental disorder, this schedule has been very helpful. Now the question is, why did we develop this? This schedule was developed over a period of time. The current version is 2.2. That means this version has evolved over a period of time. This version is an adapted version of psychiatric classification, diagnostic criteria, treatment guidelines, and referral of patients to various places. As you know, most of our diagnosis, classificatory systems are borrowed from Western countries. And also, they are all very lengthy, time-consuming, and they are not suited for Indian patients or for Indian doctors. This clinical schedule for primary care psychiatry has been adapted for Indian setting to ask questions for Indian patients by an Indian doctor. Invariably, we have seen many of the primary care physicians clearly reported they hardly see any psychiatric patients, especially severe mental disorder, and majority of the time they see common mental disorders. Hence, this primary care psychiatry schedule is focused to find out those highly prevalent psychiatric illness in primary care setting. And this clinical schedule for primary care psychiatry is focused to train primary care doctors so that in their busy schedule they are able to pick up psychiatric patients in their general hospital outpatient setting, and also to find those highly prevalent psychiatric disorders which are mentioned in this clinical schedule. Now the question is, why this schedule? This schedule, as I mentioned earlier, 30 to 40% of the patient reporting primary care setting, community health centers, district hospitals, or even in a private practice, they are all 40% of them have comorbid psychiatric condition. That means majority of these patients are under-recognized, untreated, undiagnosed. Hence, this schedule is targeted to identify those common mental disorders by the primary care doctor. Who can use this? Any doctor can use it. But however, this primary care psychiatry clinical schedules is targeted to general practitioner, primary care doctors, family physicians, any physician who is doing private practice, and specialist treating chronic medical condition can utilize this clinical schedules for primary care psychiatry. What is expected by using these clinical schedules? First and the foremost, it is used for OPD screening of psychiatric diagnosis. Second, to start first line of treatment. Referral, if no improvement is seen in 4 weeks, if there is severity of illness, to refer, and to do follow-up. That is what is expected by using clinical schedules for primary care psychiatry. Where to use this? This is used in a busy OPD screening. That means in adult patients, in a OPD it can be used. And this schedule hardly takes 5 minutes if you have undergone thorough training. That means you need to use this schedule over a period of 1 to 2 months on regular basis, and it becomes easy to diagnose psychiatric condition in general hospital setting. And there should be a reliable informant available along with the patient to make accurate diagnosis. Now the question is, what are those common mental disorders covered under clinical schedule for primary care psychiatry? It can be easily recognized as TAP-SAD. What is this TAP? T for tobacco disorder, A for alcohol disorder, P for psychosis, P for panic disorder, S for somatization, A for anxiety disorder, D for depressive disorder. In simple words, you can remember as TAP SAD. How to use this clinical schedule for primary care psychiatry? Here the questions are administered to the patient, patient's family members and friends, and some of the questions are allowed for interpretation by the doctor. But however, every doctor needs to undergo training in how to use this CSP version 2.2. And before you use this CSP, at least 2 cases need to be seen in each diagnostic category independently under the supervision of a trained psychiatrist, and treat them independently and do follow up over a period of 3 months. If you are able to do that, that means you are able to be trained in using clinical schedules for primary care psychiatry. Now the question is, who are these patients who present in primary care who have psychiatric illness? It is very simple to diagnose. Most of the time, our primary care doctors, family physician invariably prescribe analgesics to these patients, or else vitamin, tonics, antacids are repeatedly given to these patients. Many a time benzodiazepines are given. IV fluids or injections are given to these patients. These patients present with vague, unusual symptoms. Whenever our doctors see these patients, they get frustrated. For simple reason, our doctors do not know how to treat them, and they feel they are incompetent to deal with certain cases. And they label them by telling that Hatha-Pava syndrome, Mykhainov syndrome, and various places have various name given to these patients. Invariably, these are all patients having common mental disorder. Unfortunately, our doctors are not being trained during their MBBS to treat, to diagnose common mental disorder. Hence, my dear friends, clinical schedule for primary care psychiatry is targeted to teach what they are supposed to learn during their MBBS. Hence, these doctors are general doctors, physicians, family physicians, specialists treating chronic medical condition, should proactively search for psychiatric illness who present with these unusual symptoms. Now the question is, when to refer? Here in this schedule, they have clearly mentioned when to refer. Whenever the patient is dangerous to self. What do you mean by dangerous to self? Suicidal ideas, suicidal attempt. Dangerous to others. That means if they become violent towards others. Although this term dangerous to self and others looks very derogatory, stigmatizing, I apologize for using these words. But however, they are very simple to remember by the primary care doctors. If there is worsening of symptoms when the medication is given, if the patient develops unmanageable side effects with medication, if there is no improvement over a period of 2 months, probably 4 weeks, if there is no improvement, you can refer them. If the primary care doctor feels that then we want a second opinion, can be referred. However, please remember, if the patient has focal neurological deficit, such as slurring of speech, limb weakness, disorientation, facial weakness, passing urine in the clothes, passing stools in the clothes, all these cases are not psychiatric cases. They are invariably neurological or neurosurgical. That means, my dear friend, if the patient has focal neurological deficits, don't engage them. Refer them to higher centers. These are the very important things you should understand. Now, how is this clinical schedule for primary psychiatry has been organized? That means how the schedule has been divided. The schedule has been divided into 3 important parts. Part 1 is screener and also called as case record form. Part 2 is management. Part 3 is prescription module. Now, let's go through each one of them. All these part 1, 2, 3 are available within 12 pages. That means the whole clinical schedule for primary care psychiatry has only 12 pages including the cover page and the last page. So, my dear friend, it is a very simple tool which can be used by primary care doctor, family physicians, or any physicians who are treating general patients. Now, let's discuss about this clinical schedule for primary care psychiatry. As I mentioned, it has 3 parts. Let's go through each one of them. Part 1, that is the screener. Let's discuss about this screener, that is case record form. Here, it has 21 items. These 21 items, if you are able to use over a period of 1 to 2 months, you will be able to master over this, and you can use this clinical schedule for primary care psychiatry within 5 minutes, including writing prescription and counseling. Let's go through each one of them. Demographic details and guiding path. This initial part has a demographic details such as hospital number, date. If you are able to get Aadhaar number, please document that. Name, postal address, presenting complaints in a chronological order need to be present here. If you are done physical examination, please document here. Now the guiding path starts. If after listening to the patient and duration of symptoms and reason for consultation is very clear, and if you are able to attribute to a medical condition, please diagnose and treat. For example, patient has fever and also has cough, and you have diagnosed the patient is having pneumonia. Please go ahead and treat. Another example, if the patient has fever, chills and rigors, and also splenomegaly or hepatomegaly, and you are suspecting malaria, go ahead and treat. So that is what is, if the symptoms are attributed to medical condition, go ahead. Suppose if the presentation symptoms you are unable to attribute to any medical condition, symptoms are vague, the patient is repeatedly coming to the hospital, and if the duration of symptoms are less than 2 weeks, reassure them, ask them to come for follow-up if the symptom persists. If the patient reports of symptoms more than 2 weeks, then use the general health questionnaire from 1 to 21 questions. I'll repeat. If you are unable to attribute the symptoms to a medical condition and you suspect psychiatric condition, if the symptoms are less than 2 weeks, reassure them, and if the symptoms do not decrease, ask them to come back after 2 weeks. If the patient reports the symptoms are there more than for 2 weeks, then you will use the clinical schedule for primary care psychiatry. This is how, that is, can you explain the symptoms and signs to a known medical illness? Yes, go ahead and treat. If it is no, that means if the symptoms are less than 2 weeks, reassure, call them back. If the patient has symptoms more than 2 weeks, then you will use this. There are 21 questions I have mentioned. First 3 questions are general inquiry, but however, they are very important, which will help you in treating the patient. First question is, how is your sleep? Check. How the sleep is, they have difficulty in going to sleep, difficulty in maintaining sleep, or else early morning awakening. That needs to be checked. How is your appetite? That means whether there is a loss of appetite, loss of weight is there, that needs to be inquired. How is your interest in doing your daily work? For example, you will ask, is he getting bored by watching television, talking to family members? Is he losing interest in playing with kids or children, watching good movies, also having the dish which he likes most? So these are the general inquiry questions you will document, whether they are normal or disturbed. Now we are moving into a specific questions. Question number 4, 5, 6 discusses about alcohol disorder. Question number 4 talks about, in the past year, are you drinking alcohol heavily or regularly? If yes, please tick that. In the past year, are you not getting sleep without alcohol? Yes or no? Sixth one, in the past year, are you getting shaking of hands? Body, whenever you reduce or stop alcohol. If any one of the question is yes, go through the diagnostic criteria which is present in the clinical schedule. Now, moving to the second important, tobacco addiction. For tobacco addiction, there is only one question. The question is, do you use BD or cigarette or gutka or any other tobacco products within 1 hour of getting from the bed in the early morning? Many of the patients who are addicted to tobacco or nicotine, within 1 hour of getting up, they want to use this because invariably who use tobacco regularly will develop constipation. Hence, they need tobacco for bowel movements. Hence, it is easy to diagnose tobacco dependence by this simple question. Moving to the third, question number 8 and 9. Question number 8. It is, in the past few weeks, did you get sudden attacks of fear or anxiety? Yes or no? In the past few weeks, does the above attacks come without any reasons? If it is yes, that means you will go through the panic disorder criteria. Moving to the next, that is generalized anxiety disorder. Question number 10 and 11. Question number 10. In the past few months, are you often getting tensed, stressed up with no reason or for small trivial reason? Next, question number 11. In the past few months, are you unable to control or stop this tension? That is generalized anxiety disorder, my friends. And any one of the question is yes, go to the diagnostic criteria. Moving to the depressive disorder. Question number 12, 13 and 14. Question number 12. In the past few weeks, have you been feeling tired all the time? Question number 13. In the past few weeks, have you lost interest or pleasure in your regular daily activities? Question number 14. In the past few weeks, have you been feeling sad or depressed? If any of the question is yes, go through the diagnostic guideline. Moving to the somatization disorder. Here, question number 15 and 16. Somatization disorder is very easy to diagnose. The question should be asked is, in the past many months, does this patient have any physical symptoms which are listed in the diagnostic criteria which are unable to be explained by medical condition? If the patient have multiple somatic complaints, unusual symptoms like electrical sensation, warm sensation, cold sensation, and also symptoms cutting across various disciplines. Patient has cardiac pain, patient has abdominal pain, backache, leg pain, twisting of legs. So unusual symptoms are there. That means there is high possibility you are dealing with somatization disorder. Question number 16. In the past many months, does this patient show the signs of doctor shopping for physical symptoms? So, my dear friend, this is somatization disorder. Moving to the question number 17 to 20. This deals with psychotic disorder. Although there are 4 questions have been dedicated for psychotic disorder, it is very easy to diagnose psychotic disorder. Go to any village, ask the Asha worker, any person in your village have any psychiatric illness? Invariably, Asha worker will be able to name the patients who have violence, abnormal behavior, talking to self and smiling to self. That means to diagnose psychotic condition, you don't require MBBS degree. A simple 10th standard pass will be able to say, yes, this person have mental illness, which is severe mental disorder. Let's look into those questions. Question number 17. In the past few weeks, does he or she have talking to self, smiling to self, or else hallucinating? Question number 18. In the past few weeks, does he or she have poor self-care, wandering aimlessly, or roaming around? Question number 19. In the past few weeks, does he or she have suspiciousness, big claims, or delusion? Question number 20. In the past few weeks, does he have talking to excessively, sleeping less, hyperactive, dancing? So these are the 4 questions which indicates severe mental disorder. And final question is very, very essential. That is, dangerous to self or others. Dangerous to self means suicidal attempt or suicidal ideas. Dangerous to other means becoming aggressive to others. In such a scenario, this is a psychiatric emergency. You need to do psychological first aid and refer them to a higher center. Enquiry guidelines. That is the last part of it. Here, items are very clear. Question number 1 to 15 needs to be directly targeted to the patients. However, question number 18, 19 and 20 needs to be asked to the family and friends of the patients. Question number 16, 17 and 21 are for clinical interpretation by the doctor. And please remember, my dear friends, question number 21 is a psychiatric emergency, that is dangerous to self, that is suicidal ideas and attempt, dangerous to others. These are the patients where we need to do psychological first aid to the patient and family members and refer them to the higher centers. Now, moving to the important part, that is behavioral observation and diagnosis. Here, the part 1, whatever the patient's behavior noted during the interview of the patient and family members need to be documented here. Moving to the second part is the diagnosis. If the patient has alcohol use disorder, document it here, whether it is harmful use or addiction. Tobacco addiction and the common mental disorder if the patient has, whether it is depression, whether this is anxiety, whether this is somatization or mixed anxiety and depression need to be documented here. Severe mental disorder need to be documented, and finally the treatment plan, whether the prescription is given, brief counseling, follow-up date, follow-up notes, and if you are referring the patient need to be documented here. Moving to the second part, that is management guidelines, which includes diagnostic guidelines, investigation guidelines, treatment guidelines, and follow-up guidelines. Let's go through each one of them. Diagnostic guidelines. Here in this part 2, this clinical schedule for primary care psychiatry clearly gives diagnostic guidelines for all the 7 disorders, starting from alcohol disorder, tobacco disorder, somatization disorder, further for panic disorder, psychosis, depressive disorder, and also for anxiety disorder. Whenever you suspect any of these, from asking question 1 to 21, please go through this diagnostic guideline, confirm yourself, yes, the patient has this diagnosis. Once you diagnose the patient, now the question is, should you ask for any investigation? Invariably, in psychiatry, there is no diagnostic lab test. That means there is no blood test or else CT scan, MRI or any imaging studies which positively diagnoses psychiatric illness. That means psychiatry is directly dependent upon your clinical interview method. That means here the complete competency of diagnosing psychiatric illness is based upon doctor's clinical interview skills. In psychiatry, you don't require any investigation to diagnose, but however, you need to use investigation to rule out organic conditions such as head injury, maybe tumor in the brain, or else any stroke. In such a scenario, you will use imaging studies such as CT scan and MRI. Invariably, they are rarely used in psychiatry. That means to diagnose psychiatric condition, it is not required. But however, to diagnose neurological and neurosurgical condition, it is required. But however, in psychiatry, investigation is used such as thyroid function test to know whether the patient has hypothyroidism related depression, or when you give antipsychotics or antidepressant, you need to know the heart condition, especially in elderly population if they have ischemic heart disease, hence ECG is done. However, investigation in psychiatry is focused mainly on monitoring the medication, such as to know serum lithium level and also to know other parameters such as kidney function test, liver function test, and other conditions. Now let's understand the treatment guideline. Here, after your diagnosis, and since invariably the investigations are very few in psychiatry, you will go for treatment. Here, this clinical schedule for primary care psychiatry gives the treatment guidelines. The diagnosis is there and also the medications are clearly written. Further, the part B, it talks about counseling. Again, counseling needs to be understood. That means you'll be doing within 5 minutes. Majority of our primary care doctors do counseling to their patient. It will be around 2 to 3 minutes. Here also in primary care psychiatry, you will be focusing on counseling by educating that these symptoms are signs of psychiatric disorder. These require medication. Medication may be 1 to 3 months and medications to be taken regularly. Further, need for follow-up will be emphasized here. And also, the importance of yoga, meditation, relaxation, and also healthy lifestyles will be emphasized during this counseling. And please don't confuse counseling with psychotherapy. Psychotherapy requires 45 minutes to 1.5 hours, whereas counseling with regard to in primary care psychiatry, it is hardly 5 to 10 minutes. So my dear friends, counseling is with regard to medication, with regard to supervised medication, with regard to regular follow-up, and emphasizing it is a medical illness. Further, the medications which can be given as a first line of treatments are also being mentioned here, from selective serotonin reuptake inhibitors, antidepressants, tricyclic antidepressants, antipsychotics, typical antipsychotics, and also injectables. Here, antipsychotic injectables should be given whenever the patient has poor compliance for medication. A patient with chronic psychosis refusing to take medication should be given antipsychotic depot preparation. Invariably, this depot preparation, once it is given, it will be there in the blood for 15 days. For example, injection flufenazine deconate, if it is given once every 15 days, the patient need not take any oral medication. One injection for 2 weeks is enough to control his symptoms. Hence, my dear friends, injectables should be given only when the patient refuses to take medication. Further, extrapyramidal side effects have been clearly mentioned, and what are the treatments have been already mentioned. Treatment with regard to alcohol and tobacco has also been mentioned in this clinical schedule for primary care psychiatry. Further, treatment for tobacco addiction and also guidelines have been clearly given with regard to comorbid medical condition. Now, if the patient has comorbid medical condition, please remember this. If the patient has a medical condition and also a psychiatric condition, medical condition like such as diabetes, hypertension, ischemic heart disease, stroke, cancer, and other chronic medical condition, start slow, go low. Avoid polypharmacy in these patients. And if you have doubt, please refer them to a psychiatrist. And again, I am emphasizing in pregnancy and lactation, general rule is avoid these medication in the first trimester, exercise caution in the second and third trimester. I would request you to refer them to a psychiatrist. Coming to the follow-up guidelines. Follow-up guidelines, you need to understand. In the first follow-up, you should be giving after 2 weeks. After 2 weeks, look for side effects like extrapyramidal symptoms, tremor. If there are no side effects, call them after 2 weeks, that is approximately after 1 month. Look for the effect of medication, whether the symptoms are improving or not. If the symptoms are not improving, ask whether the patient is taking medication regularly, whether it is supervised. If the patient is not taking medication regularly, please refer them to a psychiatrist or else ask them to take medication regularly. If the patient says he has improved but less than 50%, that means you are going to increase the dosage. If the patient reports he is improved more than 50%, continue the same dosage of medication. Many a time patient may not be able to verbalize percentage. Ask them, out of 1 rupee, how many paisa improvement is there? Patient is invariably will say 30%, 30 paisa, 50 paisa, they will be able to quantify easily. So in follow-up, my dear friends, first follow-up is to look for side effect. The first follow-up is after 2 weeks. Second follow-up is after 4 weeks to assess for the improvement. So coming to the last part of it is, my dear friend, part 3 is prescription module. Many a time, our MBBS doctors, general physician, primary care doctors find it very difficult to prescribe psychiatric medication. Hence, we have given how to write a prescription for psychiatry. Although many of our doctors know how to write prescription, but however, they may not be able to have that strength to write psychiatric medication. If you look at the depression, clearly fluoxetine 20 mg 100 should be written, clonazepam 0.25 mg 001. Similarly, for each medication, the prescription is written, and the patient and the doctor needs to write one prescription and counsel the patient in the presence of psychiatrist. If he is able to do this and able to do the follow-up, that means he is able to learn this prescription module. Once he is able to write the prescription and monitor the side effect, he will become a good primary care doctor by identifying the psychiatric illness and administering first line of treatment. Further, treatment for addiction is clearly mentioned, and how the prescription should be written with regard to benzodiazepines, and also how to taper those medications have been clearly documented in the clinical schedule for primary care psychiatry, my dear friends. To conclude, clinical schedule for primary care psychiatry is for general doctors, primary care doctors, family physicians, and any doctors who are doing private practice, where 30 to 40% of the patient who present to them have psychiatric diagnosis. Many a time, these diagnoses are under-diagnosed. Invariably, they have never been diagnosed. They have been given wrong treatment. Clinical schedule for primary psychiatry helps to diagnose this condition, helps the doctor to give appropriate treatment, appropriate follow-up, at the same time to guidelines for referral. But however, before using this clinical schedule for primary care psychiatry, please undergo training, my dear friends. Once you are able to undergo training and use this clinical schedule for primary care psychiatry for diagnosing at least 2 to 3 cases in each diagnostic category, you will gain the mastery over this clinical schedule. Remember, clinical schedule for primary care psychiatry helps you in diagnosing, starting first line of treatment, doing follow-up, and referral, my dear friends. Thank you very much for your valuable time. Stay safe.